Okay, so what we're going to discuss next is airway management and respiratory emergencies. Now, one of the things you're going to notice is that I'm not covering every protocol in detail. You can read them. Your training in OEC qualifies you to do most of the things that are described in these protocols simply based on that training. You should know how to do them without me telling you how to do them. So I'm not going to cover things that are already part of your basic training or things that get covered in the refresher. I'm really going to focus on things that are in addition to your training based on the protocols. So you're responsible for everything in the protocols, but most of it you already know how to do. So airway management. If we're worried about trauma, we start with C-spine management. If we're worried about trauma, we'll then open the airway using a jaw thrust or modified jaw thrust maneuver. If we're not worried about trauma, then we can use a head tilt chin lift. We'll apply oxygen. If a patient is in distress or is unresponsive, they need oxygen. You use your judgment to decide who that is. If need be, you'll do positive pressure ventilation using the bag valve mask. And that's a skill that we'll go over as part of our other skills checkoff because it's one that people often do wrong and that really requires good skill to do. If there are liquids in the airway or small particulate objects, we clear them with suction. And if the patient has no gag reflex, we place an airway adjunct, either a King airway, so a periglottic device designed to isolate the stomach and isolate the trachea and preferentially put ventilation into the lungs. If we can't get one of those in, an oral or a nasopharyngeal airway. And anytime we need to actively perform airway management, we need to request an ALS EMS response, not a BLS EMS response. And we'll talk more about the King airway and what your responsibilities are once you place it in the actual skills. But if you read through the protocols, you can also see basically if you've placed it, until you give it to somebody qualified to manage it, you own it. So what do we do in that case? You will transport with the patient. So if it's a BLS ambulance service, they cannot place a King airway, they cannot maintain the King airway. If you put a King airway in, don't pull it out. That's not in the patient's best interest. Leave the airway in, you transport with the patient, and you call me immediately. And my phone number is in the protocols. Call my cell phone, contact me immediately so that I can figure out how we're going to make that all work in the region with state EMS. If the patient is in respiratory arrest but not cardiac arrest, just follow the American Heart Association respiratory arrest guidelines that are part of your CPR training. You manage the airway per protocol, what we just went over. If they're in cardiac arrest, we use the American Heart Association guidelines, whatever year is most current, and those are what we'll follow. We'll talk more about cardiac arrest later because it's very important that we do it right in our environment. If the patient has an obstructed airway, use the obstructed airway management skills that you will have from your CPR training. And if someone's in respiratory arrest, call for advanced life support EMS, not a basic life support response. If someone is in respiratory distress and they're wheezing and they have an inhaler and they can't use their own because they're in so much respiratory distress, call online medical control, and 973-8000 is the number to the Eastern Maine Emergency Department if there's not someone who can do medical control on scene. Tell them the name of the medication and they'll tell you how many puffs to give from the inhaler. If the patient gets better after 1 or 2 puffs, they feel good again, you're kind of wondering why they came to you in the first place, you can discharge them as long as there's someone who can stay with them and help them if they need help. If they're not getting better, then they need to be transported by EMS, and they need to go ALS. They need to get the nebulizer treatments and possibly IV steroids and possibly epinephrine if they're really, really sick. So our focus is on making sure the patient is not really, really sick, and if they are, getting them out by ALS EMS. If we think someone is in heart failure with pulmonary edema, fluid in the lungs, give them oxygen, non-rebreather, 15 liters per minute. If they're in respiratory failure but still breathing, so they're clearly not getting enough oxygen in, you put the bag valve mask on their face, you begin to do assisted ventilation, and that's a skill you should have practiced elsewhere. You request ALS EMS. They're going to need medications, and if their systolic blood pressure is greater than 100, sit them up with their legs dangling. That pools fluid and may get fluid out of the lungs. Okay, you can go ahead and finish the knowledge assessment associated with these series of protocols and all of the protocols on respiratory distress.